I'm about to reveal something that might shock you, something that's going to sound completely backwards from everything your doctor has told you about cholesterol. What I'm going to share today could prevent a heart attack in the next 30 days, and it has nothing to do with your total cholesterol number that your doctor keeps obsessing over. If you're dealing with triglyceride levels above 150 that your doctor says are borderline high, that keep climbing despite taking medication, that make you worry every time you get blood work done, that leave you confused about what numbers actually matter for your heart, then you need to understand what I'm about to explain. Your confusion isn't your fault. The medical establishment has been so focused on LDL cholesterol that they've completely overlooked the most dangerous lipid particle in your bloodstream. But here's what's critical. High triglycerides in seniors aren't just a number on a lab report. They're a warning sign that your metabolism is broken, that your liver is producing deadly fat particles called VLDL that are far more dangerous than LDL, and that you're on a direct path to heart attack, stroke, or sudden cardiac death. And depending on which type of lipid elevation you have, the wrong treatment approach could actually accelerate your cardiovascular disease, while the right approach could reverse it completely. I'm Dr. Claire Whitmore, and after 20 years as a cardiac surgeon, I've performed over 3,000 open heart surgeries. I've diagnosed advanced coronary disease from triglyceride patterns that patients ignored for years because their doctors told them their cholesterol was fine. I've seen the heart attacks, the emergency bypass surgeries at age 70 when prevention was possible at age 60. The widows who thought their husbands were healthy because LDL was under control. And I've taught thousands of seniors the exact protocols I'm about to share with you that lower VLDL production, normalize triglycerides, and dramatically reduce cardiovascular risk through mechanisms completely different from statin drugs. What I'm going to give you in this video is worth more than what most cardiologists charge for multiple office visits. You're getting a complete diagnostic framework to identify whether VLDL or LDL is your primary problem, the exact protocols to address each type with specific supplements and lifestyle modifications, the blood test numbers that reveal metabolic dysfunction your doctor isn't checking, the medication interactions that raise triglycerides that nobody warns you about, and the emergency warning signs that mean you need cardiac evaluation immediately, not next month. This isn't generic cholesterol advice. This is advanced lipidology that most primary care doctors never learned in medical school. Stay with me through every minute because missing one piece could mean the difference between preventing a cardiac event and ending up in the emergency room with chest pain. What you're about to learn could literally save your life in the next 30 days. This is practical, actionable information based on the latest cardiovascular research that you can implement today and see changes on your next lipid panel. Let me start by telling you about 5 critical differences between VLDL and LDL that determine which one is actually killing you, because the answer isn't what you think. Your doctor has been measuring the wrong number, and I'm going to show you exactly why. Difference number 1 is particle size and arterial penetration capability. VLDL stands for very low-density lipoprotein. This is the largest lipid particle your liver produces, measuring 60 to 80 nanometers in diameter. It's packed with triglycerides, which are fat molecules your liver manufactures from excess sugar and refined carbohydrates you consume. LDL stands for low-density lipoprotein, measuring 18 to 25 nanometers. It's much smaller and denser than VLDL. Here's what you need to understand about why size matters desperately for your cardiovascular risk. Small, dense LDL particles penetrate your arterial walls easily. Think of them like tiny bullets that slip through the gaps in your arterial lining. Once inside the arterial wall, they oxidize, triggering inflammation that builds arterial plaque. Large, fluffy VLDL particles are too big to penetrate healthy arterial walls initially. But here's the deadly mechanism nobody explains. As VLDL circulates through your bloodstream, an enzyme called lipoprotein lipase strips away triglycerides, shrinking the VLDL particle progressively. It transforms first into IDL, intermediate density lipoprotein, then into small dense LDL, the most dangerous form. One VLDL particle eventually becomes multiple small dense LDL particles that penetrate your arteries and cause plaque buildup. If your triglycerides are above 150, your liver is overproducing VLDL constantly. Every single VLDL particle your liver releases will eventually become small dense LDL. You're manufacturing the exact particle type that causes heart attacks. Your standard lipid panel that just shows total cholesterol and LDL misses this completely. The number your doctor celebrates as good LDL under 100 might consist entirely of dangerous small dense particles if your triglycerides are elevated. This is why people with normal LDL still have heart attacks. Let me give you a diagnostic test you can do right now using your last lipid panel. Find your triglyceride number and your HDL number. Calculate the triglyceride to HDL ratio by dividing triglycerides by HDL. If your result is above 2, you have predominantly small, dense LDL particles, regardless of what your total LDL number shows. If your ratio is above 4, you have severe small particle predominance and your cardiovascular risk is extremely high, even if your doctor said your cholesterol looks fine. This ratio predicts heart attack risk better than LDL alone. Difference number 2 is the metabolic origin and what causes elevation. LDL elevation typically results from dietary saturated fat and cholesterol intake combined with genetic factors affecting cholesterol metabolism. Your liver produces LDL, but dietary fat influences how much. VLDL elevation results from an entirely different mechanism. It's caused by excess carbohydrate consumption, insulin resistance, fatty liver disease, and metabolic syndrome. Here's the critical metabolic pathway you must understand. When you eat carbohydrates, especially refined carbs and sugar, your blood glucose rises. Your pancreas releases insulin to drive that glucose into cells. But if you're insulin resistant, which most seniors with elevated triglycerides are, your cells don't respond properly to insulin. The glucose can't enter cells efficiently. Your liver converts that excess glucose into triglycerides through a process called de novo lipogenesis. It then packages those triglycerides into VLDL particles and releases them into your bloodstream. The more carbohydrates you consume, the more VLDL your liver produces. This is why low-fat, high-carb diets that doctors recommended for decades actually increase triglycerides and cardiovascular risk. You were told to avoid fat and eat whole grains. Your triglycerides climbed because those whole grains became glucose, became triglycerides, became VLDL, became small dense LDL, became arterial plaque. The dietary advice was biochemically backwards. If your triglycerides are elevated but your LDL is normal or even low, your problem is metabolic and carbohydrate-driven, not dietary fat-driven. Taking a statin drug that lowers LDL won't fix your triglyceride problem because it doesn't address the underlying insulin resistance and excessive hepatic VLDL production. This is why some people take statins for years, get their LDL down to 70, and still have heart attacks. They're lowering the wrong lipid particle, while VLDL and small dense LDL continue damaging their arteries. Difference number 3 is cardiovascular risk prediction accuracy. Standard medical practice focuses obsessively on LDL cholesterol. The guidelines say LDL should be under 100 for most people, under 70 if you have cardiovascular disease. Doctors prescribe statins primarily to lower LDL. Insurance companies use LDL targets to measure quality of care. But here's what the research actually shows. Triglyceride level predicts cardiovascular events more accurately than LDL in multiple large studies. The Copenhagen City Heart Study, following over 10,000 people for 22 years, found that elevated triglycerides predicted heart attack risk independent of LDL and HDL levels. People with triglycerides above 443 had 16 times higher risk of heart attack compared to those with triglycerides under 89, regardless of their LDL cholesterol. The Emerging Risk Factors collaboration analyzing over 300,000 people found that triglyceride-rich lipoproteins, meaning VLDL and its remnants, cause atherosclerosis directly. These particles don't just correlate with heart disease, they cause it through inflammatory mechanisms independent of LDL. Advanced lipid testing that measures VLDL particle number shows that VLDL particle count predicts cardiovascular events better than LDL particle count in insulin-resistant patients. If you're a senior with metabolic syndrome, which includes abdominal obesity, high blood pressure, elevated fasting glucose, and high triglycerides, your VLDL is far more dangerous than your LDL. But your doctor is probably still focused entirely on your LDL number because that's what the guidelines emphasize. This focus on the wrong target explains why cardiovascular disease remains the #1 killer despite widespread statin use. Difference number 4 is treatment approach and what actually works. LDL responds well to statin medications. Statins block an enzyme called HMG-CoA reductase that your liver needs to manufacture cholesterol. Less cholesterol production means lower LDL. Statins typically reduce LDL by 30 to 50%. They're effective at what they do. But statins barely affect triglycerides and VLDL. A typical statin might lower triglycerides by 10 to 15%, which is insignificant if your triglycerides are 300. Some statins, particularly Crestor and Lipitor, actually raise triglycerides slightly in some patients. If your primary problem is VLDL overproduction, statins won't solve it. VLDL responds to completely different interventions. Carbohydrate restriction is the most powerful intervention for VLDL reduction. Multiple studies show that low-carb diets reduce triglycerides by 30 to 50% within weeks, far more effectively than statins reduce LDL. When you restrict carbohydrates below 75 grams daily, your liver has less glucose to convert into triglycerides. VLDL production drops dramatically. Triglycerides fall, small dense LDL decreases. Cardiovascular risk declines significantly. Omega-3 fatty acids from fish oil specifically target VLDL production. The prescription omega-3 medications Lavazza and Vascepa reduce triglycerides by 20 to 50% through multiple mechanisms. They reduce hepatic VLDL synthesis. They increase VLDL clearance from the bloodstream. They enhance lipoprotein lipase activity that breaks down triglycerides. The dose matters critically. You need at least 2 to 4 grams daily of EPA and DHA combined to significantly lower triglycerides. The typical fish oil supplement containing 300 milligrams per capsule won't accomplish anything meaningful. Fibrate medications like fenofibrate specifically lower triglycerides through different mechanisms than statins. Fibrates activate PPAR alpha receptors that increase fatty acid oxidation and reduce VLDL secretion from the liver. They lower triglycerides by 30 to 50%, far more effectively than statins. Yet doctors prescribe statins to 90% of patients with lipid abnormalities and fibrates to maybe 5%, even when triglycerides are severely elevated. Difference number 5 is the warning signs and emergency situations each creates. Severely elevated LDL rarely causes acute symptoms. It builds plaque gradually over decades. You feel fine until suddenly you're having a heart attack. There's no warning system alerting you that your LDL is damaging your arteries today. Extremely elevated triglycerides above 500 create an acute dangerous condition called acute pancreatitis. Your pancreas becomes inflamed from the excessive fat particles in your bloodstream. You develop severe upper abdominal pain that radiates to your back, nausea and vomiting that won't stop. Fever, rapid heartbeat. This is a medical emergency requiring hospitalization. Acute pancreatitis kills 10 to 30% of people who develop the severe form. Triglycerides above 1,000 create immediate pancreatitis risk. This is an emergency that LDL elevation never causes. Triglycerides above 500 also create a condition called lipemia retinalis, where the blood vessels in your retina appear creamy white instead of red because your blood contains so much fat. An eye doctor seeing this during a routine exam knows immediately you have severely elevated triglycerides requiring urgent treatment. Extremely high triglycerides also cause eruptive xanthomas, which are yellowish fatty deposits that appear suddenly on your skin, particularly on your buttocks, shoulders, and arms. These are visible warning signs of metabolic crisis. Most importantly, elevated triglycerides combined with low HDL create the most dangerous lipid pattern for sudden cardiac death. This pattern indicates severe insulin resistance, widespread endothelial dysfunction, inflammatory state, and prothrombotic tendency, meaning your blood clots more easily. This is the exact profile that causes the sudden heart attack in someone whose doctor said their cholesterol was fine because the doctor only looked at LDL. Now let me address a dangerous myth that's causing tremendous harm. Some people think they can lower triglycerides by eating less fat. You might believe this because it seems logical. Triglycerides are fat in your blood, so eating less fat should lower them, right? This is completely backwards and demonstrates a fundamental misunderstanding of lipid metabolism. Here's why this myth is wrong and dangerous. Dietary fat consumption doesn't significantly raise triglyceride levels in most people. When you eat fat, it's absorbed in your intestines, packaged into chylomicrons, and cleared from your bloodstream within hours. This is postprandial lipemia, which is temporary. Your fasting triglyceride level, measured 12 hours after eating, reflects VLDL production by your liver, not dietary fat consumption. The macronutrient that raises triglycerides is carbohydrate. particularly refined carbohydrates and sugar. Excess carbohydrate beyond what your body needs for immediate energy gets converted to fat through de novo lipogenesis. Your liver manufactures new triglycerides from glucose and packages them into VLDL. High carbohydrate intake, especially when combined with insulin resistance, dramatically increases hepatic VLDL production and raises fasting triglycerides. Multiple controlled feeding studies prove this definitively. When researchers feed people low-fat, high-carb diets, triglycerides increase. When they feed people high-fat, low-carb diets, triglycerides decrease dramatically. A meta-analysis of 23 randomized trials published in the American Journal of Clinical Nutrition found that low-carb diets reduce triglycerides significantly more than low-fat diets, with the magnitude of reduction proportional to the degree of carbohydrate restriction. The correct approach to lower triglycerides is to reduce carbohydrate intake, particularly eliminating sugar, fruit juice, refined grains, and starchy foods. Increase healthy fat consumption from sources like olive oil, avocados, nuts, fatty fish, and eggs. This seems counterintuitive, but it's biochemically correct. Your triglycerides will drop, often dramatically, within 2 to 3 weeks of carbohydrate restriction, even while consuming more dietary fat. Here's your complete action checklist to implement starting tonight. 1. Get your last lipid panel and calculate your triglyceride to HDL ratio. If it's above 2, you have small, dense LDL predominance requiring immediate intervention. 2. If your triglycerides are above 150, schedule an appointment with your doctor to discuss adding a fibrate medication or high-dose omega-3 prescription. 3. Eliminate all sugar, fruit juice, bread, pasta, rice, and potatoes from your diet immediately. These are the primary drivers of VLDL overproduction. 4. Increase your omega-3 intake by eating fatty fish like salmon, mackerel, or sardines 3 times weekly, or taking a high-quality fish oil supplement providing at least 2 grams of combined EPA and DHA daily. The brand I recommend is Nordic Naturals Ultimate Omega, with 1,300 milligrams of omega-3s per 2 capsule serving. Take 4 capsules daily with food to minimize fishy aftertaste. 5. Request advanced lipid testing called NMR lipoprofile or cardio IQ that measures VLDL particle number, LDL particle number, and small dense LDL percentage. This reveals your true cardiovascular risk that standard lipid panels miss. 6. If you're taking a statin, but your triglycerides remain elevated above 150, discuss with your doctor whether adding a fibrate or switching from statin to fibrate monotherapy makes more sense. Some people need both, but triglyceride elevation requires fibrate therapy that statins don't provide. 7. Check your fasting insulin level, not just fasting glucose. Elevated fasting insulin above 8 indicates insulin resistance driving VLDL overproduction, even if your glucose is still normal. 8. Consider adding berberine supplement, which reduces hepatic glucose production and improves insulin sensitivity. The dose is 500 milligrams 3 times daily with meals. 9. If you have metabolic syndrome with abdominal obesity, start measuring your waist circumference. Visceral fat around your organs drives insulin resistance and VLDL production. Waist circumference above 40 inches in men or 35 inches in women indicates dangerous visceral obesity requiring intervention. 10. Add resistance training twice weekly. Muscle tissue is highly insulin sensitive and serves as a glucose disposal site, reducing the glucose available for triglyceride synthesis in your liver. 11. Monitor your triglycerides with repeat testing every 6 to 8 weeks as you implement these changes. You should see significant reduction within 8 weeks if you're doing the protocol correctly. 12. If your triglycerides are above 500, this is a medical emergency requiring immediate treatment to prevent acute pancreatitis. Call your doctor today, not next week. 13. Check if any of your medications raise triglycerides. Common culprits include thiazide diuretics for blood pressure, beta blockers, oral estrogen, corticosteroids, and some antipsychotic medications. 14. If you're diabetic, optimize your glucose control. Poorly controlled diabetes with elevated blood sugars dramatically increases hepatic VLDL production. Every 100-point increase in average blood glucose increases triglycerides substantially. 15. Implement time-restricted eating where you consume all food within an 8 to 10-hour window daily. This improves insulin sensitivity and reduces hepatic VLDL synthesis during the fasting period. Now I want to share what happened with 3 of my patients who learned these principles. Margaret, 68, came to me with triglycerides of 422 and LDL of 95. Her primary care doctor told her the cholesterol was fine and didn't address the triglycerides. She had severe insulin resistance with fasting insulin of 24. We implemented carbohydrate restriction to under 50 grams daily, started high-dose omega-3 at 4 grams daily, and added fenofibrate 145 milligrams. 8 weeks later, her triglycerides dropped to 112. Her small, dense LDL converted to large, fluffy particles. Her inflammatory markers normalized. She lost 18 pounds without trying because insulin levels dropped and her body could access stored fat for energy. Richard, 71, had triglycerides of 380 and was on atorvastatin 40 milligrams that lowered his LDL to 68. Despite low LDL, his coronary calcium score showed extensive arterial calcification. Advanced testing revealed 90% of his LDL particles were small and dense. We added fenofibrate, increased omega-3 to 3 grams daily, and implemented strict low-carb nutrition, eliminating all grains and sugar. 12 weeks later, triglycerides dropped to 93. Repeat coronary calcium score 1 year later showed no progression of calcification for the first time in 6 years. He avoided the coronary bypass surgery his previous cardiologist recommended. Dorothy, 65, presented with metabolic syndrome, triglycerides of 570, and acute risk of pancreatitis. She was hospitalized immediately, given intravenous insulin to rapidly lower triglycerides, then started on prescription omega-3 and fenofibrate. We implemented ketogenic diet with carbohydrates under 30 grams daily. Her triglycerides dropped to 200 within 2 weeks, then to 140 after 8 weeks. She lost 32 pounds over 6 months. Her insulin resistance resolved completely with fasting insulin dropping from 19 to 4. She came off blood pressure medication and metformin because metabolic health normalized. Before we close, I need to talk about the warning signs that mean you need emergency medical attention, not home protocols. If you have triglycerides above 500 and you develop severe upper abdominal pain, especially pain that radiates to your back, with nausea and vomiting, go to the emergency room immediately. This could be acute pancreatitis, which is life-threatening. Do not wait until morning. Do not try home remedies. Go now. If you see yellowish, fatty bumps suddenly appearing on your skin, particularly on your buttocks or the backs of your arms, this indicates severely elevated triglycerides requiring urgent medical evaluation. If you experience chest pain, severe shortness of breath, or symptoms of heart attack while having known elevated triglycerides and low HDL, call 911. This lipid pattern significantly increases acute coronary syndrome risk. These are emergencies that require immediate professional care, not lifestyle modifications. Now, before we close, I need 3 things from you. First, subscribe to this channel right now if you haven't already. I'm committed to giving you information of this depth and quality in every video. Advanced cardiovascular medicine that actually changes your life, not surface-level health tips you've heard everywhere else. Hit that subscribe button. Second, share this video with anyone you know who has elevated triglycerides or who's been told their cholesterol is fine despite having metabolic syndrome. The people in your life whose doctors focus only on LDL while ignoring triglycerides. Send them this video. This information could prevent a heart attack or stroke that their current treatment approach won't address. And third, leave a comment. Tell me what your triglyceride to HDL ratio is when you calculate it from your last lipid panel. Tell me which element of this protocol you're most excited to implement. Ask questions if anything is unclear. I read every comment and I respond to as many as I can. Your engagement helps this critical information reach more people who desperately need it. Your heart has been beating without stopping since before you were born. Every moment of your life, it's pumped blood carrying oxygen and nutrients to every cell in your body. It deserves protection now. When your lipid panel shows dangerous patterns, your cardiovascular system is warning you that metabolic dysfunction is damaging your arteries. Listen to those warnings. Address the root problem. The protocol I've given you works by targeting the actual mechanism causing triglyceride elevation and VLDL overproduction. This isn't symptom management. This is fixing the broken metabolism. Implement it tonight. Start your journey toward normalized triglycerides, reduced cardiovascular risk, and metabolic health restoration. Take care of yourself.